here it is on a model. We printed out the patient's jaw because we did that bone segmentation. Here's the pin guide. And then this surgical guide drops over and literally stacks on top of the pin guide, and then you can place your implants. And I'll show you kind of what that looks like here.
So here you're extracting all the teeth first, then doing a bunch of bone reduction.
Correct.
And placing your implants.
Yep.
Okay.
Yep. And if I were to do this case tomorrow, I would try to do selective teeth extraction because this is just way complex in planning, in execution. So thinking like, how can I do it selective teeth extraction? And then if you can't, and you're like, there's just no way I can do it, you got to learn to do this. And so this, we went as far as even stacking the prosthetic. So this prosthetic, this temporary, was pre-designed with the holes already in it so that the cylinders come out through the holes. And then that stacked portion, we just had these little sacrificial supports printed and connected it. And so now this stacks on top of that bone reduction guide. So after the implants are placed, you take your temporary and you lay it on, or you put your cylinders on, you lay this on, and now the temporary is lined up where you planned it. You do your pickup, and then you can cut off those little sacrificial supports right here, and then, kind of a fancy way to do it. This is like the fancy digital way to prosthetically, place, your temporary in three-dimensional space and have it picked up. There's just a little bit of like acceptable inaccuracy in the process where you really don't need to do this. Like if you just print your temporary and you put your cylinders on there and you just put your temporary on and have them kind of lightly bite down and hold it and you're like, okay, that's where it needs to be, picked up, you can just pick it up. So this is just kind of like an over-the-top way to digitally like pick up this prosthetic on the cylinders. And it's really, there's acceptable inaccuracy in it. You're gonna get close enough. So here's the photo of that surgery. You can see the bone reduction guide is pinned into place. These pins are kind of holding the lip back and the flap back, which is nice because you get this big surgical view of the field. Make these guides nice and thick because there's a lot of pressure put on them. So make sure these guides are nice and thick. And then here's the palatal tissue held back by the suture just to keep it off the lingual. And when you do a big bone reduction on a ridge, you end up with a ton of this lingual extra tissue, and you just have a big lingual flap that's like super tall. Now, sometimes you can just peel it over and cut slits for your multi-units and just lay that tissue over and suture it. This case, I actually just cut away all that extra tissue. Just literally took a scissors and cut away all that extra palatal tissue, because these cases a lot of times to just granulate in really, really well underneath your prosthetic. So here's the 6 multis. You can see this is an angle, so your screw comes in this way, your screw comes in this way. This is a straight, and then this is a 17. So you can see this is the little screw that holds the multi-unit onto the implant, and then your prosthetic screws into this hole because it's redirecting this hole 17 degrees back just to be in that perfect position lingually. Cool. Any questions about that?
I have a question about previous. So when you say you're planning to have that flat on top, does your driver have? How do you know when you're placing it?
Yeah, that's a good question. It should, yes. So the blue sky, you were doing blue sky bio?
No, I don't.
Okay. So most implant companies should have some sort of line or dot and have 6 of them on their driver. So what I would do is look at your driver and look at it closely, and then look at the hex on the driver and see does the flat on the hex line up with something on my driver? Because ideally, you want to be able to just look at your driver and stop with the line or the hex or something on your driver. So, you could mark it, yeah. Yeah, you could go and you could put some marks on your own driver too. Yeah. So you can look at this case and like bloody field. They cut all that tissue, and you can see how it healed up here. So after we took the temporary off, and all the tissue had just granulated underneath the temporary, which is all keratinized tissue because that's what's on the edges of the flap. So keratinized tissue is going to grow under, and you just get a ton of thick attached tissue all the way around. So this was 3 months. Now we're ready to restore. We're going to go through after lunch, like the restorative phase, and do the PMR and show you how to restore the case when they come back. Okay. And then I'll just jump through here. There's a lot going on in this slide, but if you look at the top left here, the top, oh, nice music. So you can see her top. We built her upper to ideal because we did one after the time. Again, all digitally planned. Her occlusion was so jacked up. Her lower was like a roller coaster. And so we finished her upper, and then we recently just started her lower. And so you can see how messed up her occlusion was on that video. It's just like a big roller coaster down there. But then again, now we did her lower. So this is a temporary on the lower. Big digital wax up, all planned, all guided. We pulled all these teeth out. I left those 2 big implants in there. You know, big combination syndrome or whatnot. The big roller coaster there. So ton of bone reduction all the way down.
How do you? I think you need that to be louder.
I know, sorry.
How do you prevent them from just busting your temporary to shreds on the upper when they've got natural occlusion on the bottom that's jacked up like that, just hammering on it?
Yeah.
Did you go through a couple of temps with her or no?
No, we didn't go through any temps with her. A little bit, I guess a little bit lucky on that. Now, if you think about on the temporaries, ideally where you like her occlusion is somewhere kind of in the middle, like bicuspid area, is where I like to kind of like put the majority of the occlusal forces. You don't want to be way in the back, right, where it's like hasn't
You didn't hit anything in the back.
Nothing in the back.
Only hit like lower anteriors up on the palate or something.
Yeah, I think it was literally just I think I built her so she literally just hit right in that bicuspid area. Just left and right even.
You just added some deposit on the lower or something to balance it out? Or?
I'm trying to remember what I did. I think just how she ended up hitting was literally right in the middle because her lowers were so lingualized so that they were almost like on the palate.
Yeah,
but yeah, I like to center the occlusion in the bicuspid area because you don't want to be on the front teeth because they'll break forward. You don't want to be way in the back because they'll cantilever. So it's,
And you go into it just letting them know that it's going to be hard to eat until you do the bottom as well. Right?
Yeah, absolutely. Yes, that was exactly it. I said it's going to feel really funky and not going to be able to eat. And that was actually super.
I'm in the middle of one right now, same thing. You've seen the case I've sent you.
Yeah.
But his lower is just jacked up.
Yeah.
It's not going to line up very well.
Yeah. And it's funny, you know what I did for her? So we did the upper, and the upper was built to ideal. And she's like, it's not right, it's not set right, and it's like, I'm explaining to her, like, hey, your lower is the problem. We have to do your lower. Well, let's get the upper done first, right? And I said, let me do this. So I scanned her, and I went and I did a wax up, and I did a snap-on smile on her lower. That literally, the teeth were down here on her gingiva because her lower teeth were so back up and in. And I said, come back in a week. And I printed out a little snap-on smile, and I put it on her lower, and I said, there you go. And she bit down in that occlusion that we planned, right? And she's like, oh, I get it now, right? So she had to see it in her own mouth that her lower was so jacked up. We started the lower like the next week because she understood. And so power technology showed the patient what was wrong. It wasn't the upper, it was the lower. And then, so that helped a ton. So we did the lower. We left the 2 in the back. We put multi-units on them. We placed 4 more. Kind of a raw example of what's called partial extraction therapy. Kind of a hot topic that is really kind of freaking people out.
Root banking or whatever?
Yeah, root banking. So vital root banking is kind of like this topic that's coming out that a lot of people are trying, and especially in the canine areas, is just hacking off the teeth right at the bone level just to preserve that buccal eminence. And I mean, how often do we pull out a big canine and a part of the buccal plate comes off? Or you're just avoiding that stuff, you're preserving bone. And the idea of hacking off an unroot canal treated tooth and covering it with tissue and submerging it is very, very weird for us, I think. But studies are showing it's working. So I'm kind of playing with that. I'm not going to be a huge advocate yet until I have a little bit more data behind it. But that's something you guys.
Root banking?
Yeah, it's called root banking, root submergence technique, partial extraction therapy. There's a bunch of terms. I mean, we've seen it in wisdom teeth, right? Cornectomies, like tough wisdom teeth. Our surgeons just hack the crown off and cover it up. So it's kind of that same principle, and it's shown to work.